Yeah, start from. Okay, welcome everybody. We are on our fourth echo on dementia. So this is going to be a little bit of a smaller group than usual because of the Thanksgiving holiday. So I'd like to take this opportunity to do a little bit more round of introductions. If you all can put on your camera, if you have access to one, that would be awesome. And we'll go ahead and just start with some introductions. Of course, my name is Amber Rogers and I work at Mountain Pacific Quality Health. And then we'll just do a little bit of a round robin here. And I'm not even going to try to pronounce your name, Dr. Mara.
Priya is easier. Priya is my first name. Matpuri, it's exactly as it is spelled. So
okay, awesome. And then Mary, do you want to introduce yourself?
Sure. Hi, Mary Argonis from Mountain Pacific Hawaii office, and I'll be your IT support today.
Awesome. And then let's pop it over to John Wu. Or Wanju. Maybe not. How about Lynn Morrison? Anybody? How about Patricia Rogers?
Let's see.
Awesome.
Oh, there. Yes, I'm from Dahl Memorial in Ekalaka, Montana.
Oh, wow. You're all the way across the state.
Yeah.
And then we have Kelly, and I don't want to butcher your name. Kelly Husflone from Billings Clinic. Awesome. And then Emmy. Anybody else?
Amber, this is Lynn Morrison. I'm sorry I couldn't get my phone off mute. I'm with Mountain Pacific. I'm the UR supervisor.
Awesome. Glad you're here. Anybody else wants to just pop in and say hi? Okay, you guys are a quiet group. Okay, well, we will go ahead and get started then. So just wanted to start off with a couple of announcements. We do offer continuing nursing education credit hours for this. And to obtain that credit, you do need to attend the entire session as well as do an evaluation. So that's how we know that you've actually attended. So if you can fill out that evaluation, that is great. We use that, we look at those every week when we have these meetings. And I don't believe there's any other announcements. Oh, I did want to put a bug in your ear right now while we're still in the introduction phases. Because this is a smaller group and the didactic portion for today is a little bit limited, I do want to have a guided discussion about perhaps some more care and treatment kind of questions and open-ended. We can talk about medications and all kinds of other, like if you have a medication review sheet or you're in the midst of de-prescribing some medications, psychotropic meds, that would be awesome. Go ahead for the next slide. We do have, I do have some relevant financial relationships. All of those have been, issues have been mitigated. So there should be no issues with that. And we'll go ahead and turn it on over.
So this is our schedule, Amber?
Yep.
And you guys have access to this, I suppose. So I can send these slides over to any of you guys who want, and Amber, you can help me with that, right? So I do
Yes.
have- yeah.
What we do is I will plug it into, I'll put in our website into the chat box, and you can listen to all of the previous dementia echoes that we've had, as well as all of the other echoes that we've had on substance use disorder. And so, and the PRISM for perinatal mental health sessions that we did. So all of those are on our website, and just I'll plug that into chat.
Great. So I think we've had three, right? We had diseases causing dementia. So we talked about that. Then we have signs and symptoms of cognitive impairment and cognitive assessment tools, which are the ones that we mostly have to deal with patients that we had on the 27th. The November 10th was evaluation and diagnosis. So today's talk is mostly about, we've done this, we know what these patients are. Now we are at a primary care, or we are at, and how do we refer these people to specialist testing? So how do we refer them to specialist clinics, or how do we do specialty testing? If you guys have any questions regarding the topic while I'm talking, please let me know. Or if we have anything in general, we can leave it to the end of the talk, okay? So does it work, Amber?
Yep.
Good. Now, at the conclusion of the course, we should be able to identify patients who should be considered for subspecialty referral, list the goals of care of a person living with Alzheimer's and other dementias, develop an awareness for additional testing to confirm Alzheimer's disease and relevant research opportunities. And my disclosure is clinical management and assessment is my specialty. The genetic testing, specialty testing is something that I've read, but I've not been closely involved in real time. So any questions that I'm not able to answer, I promise I'll find the answers for you, okay? So now, how do we do the referrals? Okay, so usually it's at the discretion of the provider. Now you see a patient, we make a diagnosis, we think like we are comfortable and we're able to go ahead with it, then we are good. But if you feel, I'm a geriatric psychiatrist by profession, and I've worked in this field for about 15 years now. So it's going to be very difficult to sort of explain what I do in my real practice, because that's who I am. I'm a specialist and I treat with all these referrals. But we're going to talk with what happens at a primary care level, and more like in nursing homes and community center kind of settings. If the provider is not comfortable of we made the diagnosis, we think it is Alzheimer's or some kind of dementia going on, and now what do we do about it? Then that's the time. And if you're not comfortable, that's the time you need to find a specialist and do the appropriate referral. Now, it's also based on the comfort level of providing the diagnostic certainty, as I said, the treatment that you are able to, and the advice that you can give to family and the patient, the prognosis and the resources you have for supportive care. So it's both the comfort level of the provider and also the resources that we have, that we can manage the patient at whatever setting we are seeing these patients for the first time. Now, the patient's family interest in clinical trials as research is the next part of it. As we know, we do have treatments for Alzheimer's and other dementias, but most of it is only to slow down the process and to control the symptoms. We haven't found a cure yet, but then there are research and clinical trials happening all over the country. So if the patient and the family says hey, you know what? We have heard about this particular trial, okay? We have heard about this particular research, and we want to be referred to one of those, then definitely Alzheimer's Association, we have clinical trials, that website here, clinicaltrials.gov. And you also have local Alzheimer's disease research centers that will tell us what sort of clinical trials are available for us and what this particular patient would be eligible for. So this is only if they're interested in clinical trials and research that's going on. Now, when do we have to refer? What are the most common types when we have to refer patients and at the primary care settings that we are not comfortable treating them? Is one, we're not sure what's going on. Yes, they come up with memory problems. We do think there is some sort of dementia going on, but we are really not sure about the diagnosis. And there you go. That's one of the main reasons we could say, yes, go ahead and refer them to a specialist. Atypical presentation. So it's not clear cut like we have in the DSM-5 or we have learned in the other lectures before. They don't come in with like, an insidious onset of memory problems. The functioning has been coming down. So they might have other atypical presentations, in fact, that they're able to remember things. The memory is not a problem, but executive functioning, like, their planning, the way they cook, the way they have been able to function, the drive is actually being affected. So those are the kind of things we are thinking about atypical presentation that don't fit into the box of a regular Alzheimer's or any other dementias we are talking about. Now, the biggest thing we see in these settings is behavioral and psychiatric symptoms. What if the patient comes in with psychosis and aggression, insomnia, like, wandering behaviors, verbal agitation, and then social disinhibition. All of these things are behavioral symptoms of dementia. The psychiatric and behavioral symptoms put in as BPSD. And, we are not sure how we are going to deal with this. And we are not even sure if it's coming up from the dementia or if there is a concomitant mental illness or another reason for this. This is one of the reasons we would want to make a referral. Younger onset. So people are not the typical age after 65. They could be 50, they could be 55. I have seen people as young as 40 years presenting with cortical atrophy and presenting with symptoms of dementia. But at that time, you really want to rule out other causes of dementia before we make a diagnosis of Alzheimer's. And you need a second opinion. You're sure that, this is going on, but, it's always nice to have another person confirm your diagnosis. And if the family prefers, they say, listen, we know you're good with this, we do believe, but we need a specialist to be able to help us with this. Neurological symptoms. So you can have, like, as we already said, they can have headaches, they can have myoclonus, they can have rigidity, they have other symptoms going on. It could be Parkinson's, or they could have seizures. So when any of the neurological symptoms are going on is a time when you want to make the referral. They have, as I said, it's not a gradual decline, but there is a subacute and acute decline. The patients have been doing well, but instead of years, over years of time, like 1 year or 2 years, within months, you see there is a decline with the person. So at that time, you really want to make a referral to a specialist. And as I already mentioned, seizures. If you guys can think of any other clinical situation or any other situation that you guys have faced when you were not sure what to do with, please feel free to share. Because these are usually some of the reasons that we think referrals need to be made. But there are other things in clinical practice that we come across. If you guys can think of anything, please share your experiences. Now, when do we need additional specialty testing? And when should this be considered? So this is more or less the same as the reasons that we thought where we should be referring them to a specialist. But this is not just referring them to a specialist. So if they are referred to a geriatric psychiatrist like myself or a neuropsychiatrist, when do we consider testing is necessary? So younger onset of dementia. So these people are younger, they're younger than 65. So we want to know if there is any other reason that may be causing their presenting symptoms. Atypical presentations with diagnostic uncertainty. Like I said, if they have other neurological symptoms going on, then we really need to find out. Rapid progression. Now, recently we were talking about a CJD, Creutzfeldt-Jakob disease. There was one case that Dr. Gomi and I were talking about. The person came in, we thought it was neurological, but I think within months it progressed. And most cases within a year or two, it's fatal. So if there is a rapid progression, we would really want to think of other dementias that can be causing this. And also if there is interest in clinical trial participation. If the family or the patient says that, we would really like to be involved in clinical trials, we want to be as a part of research where they're trying to get new medications, then that's definitely when you want to do specialty testing. Sometimes you can even consider it as standard of care, but not at this point. I was just mentioning to Amber, we are working, at least I have worked in Senecity populations where we don't have a lot of resources. At this point in time, I work for nursing homes in the Wyoming and the Montana areas where we are struggling to get even MRIs done on this, we have to get them to other locations, like maybe 2 hours in distance to get even a simple things like CT scan and MRI. So what I'm saying is this is eventually when we have done everything we can within the resources that we have available, we definitely would want specialty testing if necessary. Now, it is current standard of practice to do specialty testing for most clinical trials and research and not in regular clinical practice. Now, what are the options we have for additional testing? I'm sure we have talked about the regular tests that we do. So I call it the dementia profile. So when I see a patient, this I'm talking about regular routine testing that we can get done in any of the locations we are working. So the first and foremost, we do all blood tests to make sure we're not dealing with any reversible causes of dementia. You have the CBC, you have CMP, you do the lipid profile, you get your liver and kidney functions tested. You want to know the B12 levels, folate levels, make sure that all of them are okay. The thyroid is functioning well. We get an EKG to make sure the heart is okay. And we get a regular CT scan or MRI just to make sure if we can see any cortical atrophy. On top of it, we use our tools like MMSE, MOCA, and we have many others that we are there to do the cognitive screening. We've done all of that, and we're still not sure, or the patient or the family wants a confirmed test. That's when the specialty testing comes in place. Now, as we see here, the first one we have is the cerebrospinal fluid analysis. Okay, the biomarkers are biological markers that actually measure for the level of these substances in the fluid. So we have the CSF and we test it for beta amyloid. We also test this for total tau and the phosphorylated tau. So these are the tests that we can do. Now CSF is when you do a lumbar puncture to obtain the CSF, it's not available in all places, but it's one of the easier ones to do. And the other imaging that we do, so once we also can do imaging to see the functional aspects. So when we do the regular CT and MRI, we're actually looking at the structure of the brain. Has there been any atrophy? Do you see the size of the ventricles to see how much of the cortex is atrophied? So the structural part of it is what our regular CT and MRI would show. The functional part of how the brain is working is actually what the special imaging shows us. And the functional part of it usually is how each part of the brain is using the glucose. That will tell us if this part is functioning well or not. And now for that, we do the FDG PET and the PET scans. Those are the functional kinds. They also do the functional MRIs. So these tests, you can always refer them to get their to special imaging just to confirm your diagnosis. Now, as I told you, spinal fluid analysis, you do a lumbar puncture. It's a simple test. You get in, you lumbar puncture, it's usually paid by insurance. Then you do the biomarker panel as we discussed here, right? You do the beta amyloid, the tau, and the phosphorylated tau proteins. We check for that. It's invasive, but it's safe. It's usually something that we do under local anesthesia. People are good within I have seen people go home within 1 hour or 2 hours. It's a little uncomfortable. It's not very painful, but it's very anxiety provoking. Because just the fact that you're putting a needle in the back and getting some fluid itself is anxiety provoking. But compared to the availability of other tests, this is something that's easily available. It's often performed in an office. It is done on bedside, but it depends on how much resources and help they have in that facility. This is a very technical thing. They say you can't do it in regular ones in the LP kits. You need to collect it in a polypropylene tube. I've seen it. I've never done it. I don't know what tubes they collect in. We do have kits that we can collect these. So that's the technical details of how and what to use during spinal fluid analysis for Alzheimer's. Now, this is very busy slide. It just tells you what is appropriate and what is not appropriate. So let's just go through the appropriate ones, okay? Now, patients who are considered to be increased risk for Alzheimer's, okay? So they definitely are appropriate. If they have family history, then yes, you want them to get it done. So people with increased risk of Alzheimer's, yes, you want specialty testing to be done. And then people who are less than the age of 65. Okay, we are not sure. Early onset, yes, you want them to get it done. And there are a few here. Okay, so this is that it's mild cognitive impairment that's persistent and progressing, and it is not unexplained. This is one of the things that we talked about, rapid progression, and then you definitely want to get them tested. And then you have atypical presentation of Alzheimer's, and that's when you want them to get tested. Now, the patients who have other symptoms, like, you have other neurological or psychiatric symptoms that you can't explain from where they're coming from, then specialty testing is appropriate as well. So when you get the slide, you can go through the other scenarios that are not appropriate, and we can always talk about it. Basically, what we've been deciding is if they don't fit the regular criteria, they don't fall in the regular template for a dementia or Alzheimer's, then you definitely would want a specialty testing. Now, this is a slide that shows, the amyloid to tau index. And if you have lots of it here, it shows that it's consistent with AD. This is again, very technical. It's nothing to do clinically. It just shows that you have a lot of amyloid and tau, then it is positive for consistent with Alzheimer's. Now, the different kinds of specialty testing, one we already talked about was the LP. The Amyloid Pet Scan is what they're talking about here. It's commercially available, but I don't know if any insurance will pay for this. They say it's available with VA benefits, and and there are a limited number of facilities that actually do this. Unfortunately, I'm not sure if it is done. Maybe Amber or I can find out for you guys. I don't know if it's available anywhere in Montana. Okay, I should have actually looked it up before the presentation, but I'm really not sure. It often costs a lot, but if you're a part of a clinical study, then obviously you don't have to pay for it. Now, it would show you, it's more qualitative. It'll tell you like positive or negative scan, but they are saying the severity or the progression of the disease or how far the person is in, maybe we'll be able to do that in future. But as of now, it'll just tell you if there is positive amyloid or negative amyloid. So the pictures here shows, okay, so it's a normal amyloid positive. And then when you see there is increased of amyloid. This is a functional scan. So it's actually showing us where all the amyloid is deposited. So the rightmost is normal. This is amyloid negative. You don't have anything. There's a normal amyloid positive, which is there, but this is the Alzheimer's disease. Now, the normal amyloid, I'm really not sure if it's going to be a part of an MCI or if it's going to be something that the patient is asymptomatic at this point. Now, the accuracy of the specialty testing on the biomarkers. The spinal fluid showing Alzheimer's profile, like it has low amyloid, high tau, and high phospho-tau was 95% sensitive. So that's the predictive value of these, of saying whether it is a positive test or a negative test, is pretty high in these, okay, 95 and 87. And it's specific in predicting how many people with MCI will be converted to Alzheimer's dementia. So when you have the CSF has low levels of amyloid and tau, then they are able to predict, depending on the levels, that with this person with MCI, will they be converted to an Alzheimer's dementia? Now, just to keep in mind, most of these tests are done in like, mild cognitive impairment or early levels of dementia. That's what most clinical trials are. That's where all the markers are being done. And that's where all the medication trials are being done too. Whereas with amyloid imaging, the sensitivity, they're saying that, how positive, all people who are positive really have this, is 69 to 95%. If you look at it, the range is pretty high. It's a wide range. And then you have specificity, 83 to 99%, in distinguishing normal controls from Alzheimer's disease patients in several studies. Bottom line, just because you have these, you cannot say you definitely are going to get Alzheimer's. So that's one of the reasons why people are not very comfortable in sending, like, for example, anybody who has no symptoms, okay, they just want to know that we want to get this done. It's not automatically referred, and specialty testing is not recommended just because it's not very accurate. So just because you have, like, you show some amyloid in imaging doesn't mean that you're going to develop Alzheimer's in future. So it's just going to be anxiety provoking. And that's the reason why we actually deter from sending them to these tests. So this just shows us, like, so we have the baseline, and then you treat them with an anti-amyloid drug, because I was talking about Aduhelm, right? The I'm sorry. Aducanumab is the new drug that they've been trying. It's an IV infusion. I think it's once a month in specialty centers, and it's just FDA approved recently. So I'm not sure if they use that drug, but any anti-amyloid drug is on the right side. So you see all these lighting up of the amyloid, and then this is the placebo. After treatment, you see how it changes. With the treatment, you can see that everything is going away. They do say that the clinical trials have shown a very promising response to the new drug of anti-amyloid drug, especially in people with mild cognitive impairment and mild dementias. Now, in 2018 draft guidelines, the National Institute of Aging criteria proposes that you try the amyloid, tau, and the neurodegeneration. Okay, that's how they do ATN. And you sort of do the combining of all of these to come to a better conclusion whether the biomarker combinations are supposed to be better than the single ones. So it's written here, if you are positive for amyloid, then the patient is deemed they have Alzheimer's pathophysiology. But they have both amyloid and tau, then they have Alzheimer's disease. But if they have amyloid, tau, and the neurodegeneration, the neurofibrillary tangles, then there is definitely short-term clinical progression. It's just to say that, instead of having one, they came up with these things where you have a combination of biomarkers is more sort of conclusive of the disease and rapid progression rather than just checking one. And now, as we know, spinal fluid may be the most comprehensive test as it collects the data for all three in one shot. Okay, so patients interested in research. So there are a lot of agencies that do research. You have interventional and you have non-interventional. So these are all, you have the National Institute of Health, National Institute of Aging, they have pharmaceutical sponsored, and you have the local Alzheimer's research centers. There's also Alzheimer's neuroimaging studies. There's LEADS studies that they're done as well. They compare the early onset over late onset, and there are other longitudinal studies. If you're interested, if any of your patients are interested, there is so much information on the Alzheimer's Society website, and then, it's all there. It's a short one. We are done. Now open for questions.
Let's just open it up to the group. Does anybody have some management types of questions? I can imagine that a lot of the specialty testing is not done as frequently in our rural areas of our 4-state region. Anybody have any particular testing or referral locations that you consistently use? Anybody? Does anybody have a particular case that is brought to mind that you would like to talk about and get some management kinds of advice?
Or even if you have questions about how to diagnose, or, patient comes in with these, how are we sure we're not dealing with a medical issue and we're dealing with, anything, any clinical questions, please.
You guys are a quiet group. How many folks do we have out there from that work in nursing homes in particular? Can you raise your hand or? Now I know it's too early for a turkey hangover. So,
I do have just a general question. I'm aware of a 66-year-old male. He has had long-term memory for probably 8 to 10 years. He has episodes where he becomes unbalanced. He's very shaky. He gets nauseous, vomits, just violently vomits. They've ruled out Parkinson's on him. And just probably about a year ago, he did have a fall and ended up with a subdural hematoma that had to be surgically corrected. But his memory has remained the same. It's not worsened since his incident. I don't feel like he's had a really good workup here in Montana. It's, just sort of a hit and miss. And so where would you suggest starting, with him as far as a really complete clinical workup?
So my mind, the first thing I would go is that seems more medical and neurological.
Okay.
So the way I look at it is the first thing I would want to rule out in any patient, not just people, older people with dementia, any patient who comes in with psychiatric symptoms, psychosis, depression, whatever it is, the first thing we would want to rule out is if there are any medical conditions. So in his case, are we dealing with something else that we are not sure about? Okay, does he have any strokes in the past, TIAs that has caused him to have difficulties with his walking, the fall? We are not sure about that. So the first and foremost, you would want to rule out all medical conditions and neurological issues. And then actually, once it's cleared and we say he's medically cleared, and this seems to be more of an organic brain condition that's coming up with a psychiatric issue, like dementia. Okay. The other thing that may be important to also to know after we rule out these, if there is any substances involved. I'm not just talking about illicit drugs, I'm also talking about any medications that could be causing this. Want to rule out any substances that could be causing this in terms of medications. Most anticholinergic medications, they do a lot of damage to our patients than we can even think of. They would be talking about like, oh, nothing is going on, okay, but he just takes like 100 milligram of Benadryl every day.
Right.
That's enough to cause me to not walk, okay? So, you want to make sure that polypharmacy and medications that he's on, do a good medical workup, do a very good neurological exam. The exam gives us most of the information, and then do the assessments, rule out if there is any polypharmacy, any illicit substances or medications that may be causing his symptoms before we can even think of what's going on in terms of dementia or other psychiatric issues. And it is hard. We're still struggling with a patient, a young female, and we're still not sure what's going on. They've referred to me saying that she has psychiatric issues, and it's very hard for me to believe at that age that we are just dealing with psychiatric issues. So it is very, very necessary for us to rule out medical and neurological conditions. And the sources, and as you mentioned, the resources are so limited where we work. So
yes,
it is a challenge. And this patient I was talking about, she has to travel 5 hours to get to any of the close, like a tertiary referral center. And it's very hard to find beds is what I hear. Like if you have to send them to Rapid City or, hospitals or even Billings Clinic, they have to wait because there are no beds.
Right.
So with all the resources, with what we have, we still do our best, but you're absolutely right. Okay. If we are not going to clear them medically and neurologically, it's not going to be possible to just make a diagnosis of dementia because we're still not sure what's going on.
Exactly. Thank you.
Thank you.
Questions from the group? Does anybody have a case where they really are concerned about the medication regimes or the antipsychotic medications to get those decreased? Other folks? We could play some Jeopardy music. How about any folks from Hawaii? Can we pick on some of the folks from that great state? You guys are all shy. Well, if we don't have a case or some other kinds of discussion, I think we could probably just close early, unless there's some other kinds of questions that you have. Okay.
Okay.
Sounds good. Well, thank you for standing in, and it was awesome. It was great to meet you.
Thank you so much for the opportunity, Amber. Thank you so much for attending, guys. Have a good Thanksgiving. Enjoy your break.
Awesome. Thank you. Bye-bye.
Thank you.